Thank you so much, Irene, for that really special introduction to the lectureship named for my father. And it's so significant for me and for my family that it's being used to bring two incredible speakers to us today, all the way from Scandinavia. It's my honor to introduce Dr. Olle Kampe. Dr. Kampe is a professor and senior consultant in endocrinology at the Karolinska Institutet in Stockholm, Sweden. He holds the Torsten and Ragnar Soderberg Endowment Chair in Clinical Endocrinology since 2014, and was before that professor at Uppsala University. He is a fellow of the Royal Swedish Academy of Sciences and has participated in several EU projects, of which he coordinated one, EUR-APS, dealing with APS-1. He's identified a number of the autoantibodies in clinical use for Addison's disease and APS-1, and is also responsible for national registries and biobanks for these disorders. Joining him in our keynote today is Dr. Eyestein Husebye. Dr. Husebye is a professor and consultant in endocrinology at the University of Bergen and Haukeland University Hospital in Bergen, Norway. He did his endocrine training at Uppsala University Hospital and started work in the field of autoimmune polyendocrine symptoms in the laboratory of Dr. Kampe at Uppsala University. Dr. Husebye then moved back to Bergen and started his own research group. He has participated in and coordinated several EU projects and is currently running a national registry and biobanks on Addison's disease and APS-1. And we are so looking forward to learning from the experience that they bring all the way to us from Scandinavia today. Thank you very much. Doctors.
Okay, so thank you again for inviting me. It's been very nice to be here and to meet all these people, both patients, families, colleagues, so really enjoying myself. I'm an adult endocrinologist, so I will try and talk about APS-1 from our perspective, which is a bit different from the pediatric perspective. But this, you probably know already, but APS-1 is, as we've heard, a rare disease, but in some populations it's more common, about in Finland, but also among Persian Jews, on Sardinia, it's more common. In Norway, we've calculated the prevalence to 1 in 90,000, but I think this is an underestimation. We've seen several examples that APS-1 presents in childhood, but I'll show some examples of patients that we have identified in adulthood. I won't go into all these manifestations that you've seen, but just give you some examples of some cases that we've seen. This first case is a typical APS-1 case, as we learn in the textbooks. A young boy, he got oral candidiasis when he was 1 year old. Then he followed adrenal insufficiency and hypoparathyroidism when he was 4. And later he acquired some other manifestations like enamel hypoplasia, alopecia, nail dystrophy, and also he has malabsorption and quite big problems with diarrhea. So he had a typical APS-1. He has many of these antibodies. He has a mutation in ear. The most common mutation in Norway is the 13 base pair deletion, which is also very common in the UK, in Ireland, and also been reported in North America. So there's a number of endocrine manifestations. Also quite common is ovarian insufficiency, and Olle will talk more about that. Candidiasis is mentioned, but it's not invasive candida infections. It's on the mucous membranes, on the skin and nails. But they also have a number of ectodermal dystrophies, but so we believe are really autoimmune manifestations. But the autoantigens have not been characterized for all these manifestations. But many have teeth problems. I think at least 70% of our patients have that, and we saw from NIH that they had a similar number. Alopecia is very common also, and the nail dystrophy, which can be difficult to know if it's a dystrophy or a candida infection. And we have all the gastrointestinal manifestations. But our interest in this was really Addison's disease. So when I came to Olle's lab in the early 90s, his group was working on Addison's disease. And he'd been working on diabetes, but then switched to Addison, which was known as an autoimmune disease, but it was an autoimmune disease without a known antigen. So Addison's disease, many of the patients have other autoimmune components, and APS-1 is one of them, having hyperparathyroidism and these candida infections. But most of the patients with Addison's have other autoimmune manifestations, what we call APS-2. So the typical APS-2 patient has Addison's, autoimmune thyroid disease, and maybe type 1 diabetes. So Addison's is also a rare disease, but it's more common and probably most common in the world in Scandinavia. So we recently looked at the prevalence and found even higher than written here, 20 per 100,000, we believe, is the prevalence today. So in Norway, with a population of 5 million, there's about 1,000 patients with Addison's disease. As I said, they have a lot of polyendocrineopathy, a lot of unspecific symptoms. So even if we work on Addison's in Norway, many of these patients are diagnosed late. Some of them even die before diagnosis. So we have many of the same problems with picking up these patients, as has been mentioned earlier today. So one of the hallmark findings in Addison's is this hyperpigmentation, and many of the patients get hyperpigmented, and that's what we try to learn the medical students, that they should pick up on this hyperpigmentation. Here is a drawing from Dr. Thomas Addison's original publication from 1855, beautifully describing this typical hyperpigmentation. So what Olle did in the early 90s was to identify the 21-hydroxylase autoantigen. It's one of the enzymes that participate in making cortisol in the adrenal cortex. And he also followed up with identifying another enzyme, side chain cleavage enzyme, as an autoantigen, also in Addison's patient, but also in APS-1 patients. At the same time, yet another stereogenic enzyme was found to be an autoantigen by a Finnish group led by Kai Krohn. But this finding of 21-hydroxylase really made a difference, because we now had a diagnostic tool to identify these patients early, because these antibodies appear even years before they get clinical disease. So it's a very useful marker. Olle will tell you more about. So during the 90s, we tried to collect patients. We didn't have so many patients, but we worked to try to identify more autoantigens in APS-1. And several of these were found by cloning of cDNA libraries. One of them was aromatic L-amino acid decarboxylase, or DOPA decarboxylase, which we found was associated to hepatitis and vitiligo. This was followed by finding of tryptophan hydroxylase, which is making serotonin and expressed in the gut and also in the brain. Study led by Olof Ekvall, and also tyrosine hydroxylase. So you see, these patients make antibodies against enzymes, P450 enzymes and neurotransmitter enzymes. So typical autoantigen is intracellular. It's an enzyme, and that has a very discrete tissue expression. So when you look at clinical findings and correlations, we found that 21-hydroxylase correlates or is associated to Addison's disease, and side chain cleavage enzyme is also associated to ovarian insufficiency. So 21-hydroxylase is only expressed in adrenal cortex, while side chain cleavage enzyme is expressed both in the cortex and in the ovaries. In 2006, Tony Meager and Nick Wilcox in Oxford found, stumbled over a finding of interferon omega antibodies in patients with APS-1. They'd actually described this earlier in patients with myasthenia gravis, with especially late onset and those with thymoma. But some of these myasthenia patients get candida. So as a control group, they introduced APS-1 patients and found that every patient had these antibodies. So they have antibodies against interferon omega and different interferon alpha. And typically, almost all patients have these antibodies. So it's a very good marker and quite easy to measure. At least it's much easier than doing the ER sequencing. So we use that as a screening tool. I know Mark Anderson is measuring the alpha antibodies in San Francisco, and Olle and I are measuring these in our labs. I saw recently that Fierce Labs have a commercial method for interferon omega. So I think this is also commercial available. I haven't tried that assay, but as you see here, all the APS-1 patients are positive, and different control groups don't have these antibodies. We recently developed a new method using HEK blue cells, which we find is easier to use, and it gives a very nice, difference between the patients and the controls. Anyway, another major finding in development in the APS-1 field, which was starting to picking up speed in the 90s, was cloning of the gene. It was published in two publications in Nature Genetics in 1997, and it was named autoimmune regulator. And I think when we didn't know what the gene did at that time, but I think the name was pretty good. It was a good name. Do you agree, Mark? Yeah. So it's a transcriptional regulator, and but this really inspired people to study what the function was, and kind of the person who kind of pieced this puzzle together was Mark, in a science publication very well known from 2002, where he showed that air regulates expression of proteins in the thymus. So in the thymus is kind of the T cell school. It educates the T cell, and the bad pupils, they are evicted from the school. So what air does, it expresses proteins that are normally not present in the thymus, like insulin, which is usually only made in the beta cells. Tiny amounts are also expressed in the thymus. So when T cells are exposed to insulin, and if there's a T cell that recognizes insulin, it's taken out of the repertoire. But Mark will probably explain this much better later. But at least when you have air, you have the possibility to clean your T cell repertoire from autoreactive T cells. So when air is not functioning, these comes out to the circulation and later give autoimmune disease. So air is expressed in the cell nucleus, where it does this regulation of transcription. So to date, a number of mutations are known in the ear gene. I think it's well over 100 now are reported. They're spread throughout the gene. And this black hair is a dominant mutation, and this red is the common Finnish and the common Norwegian, or the 13 base pair is located here in the PhD1 domain. But they're spread all over the gene. So Olle then, to try and get back to the title of the talk, what we have learned from European registry. So this is a rare disease. So Olle took an initiative and to a European registry and a study group, a network to study APS-1. One of the reasons was that the European Union wanted to have more research on rare diseases, and this was part of this initiative. So he pulled together a large group of scientists, clinicians, immunologists, molecular biologists, and set up this registry. So why is this important? Well, APS-1 is rare, and at that time we knew even less about the clinical picture and the natural course, and there was a lack of specific treatment, and also there was this notion that APS-1 could even teach us immunology, as Mark's finding had illustrated. So these monogenic diseases are it's kind of nature's experiments where key pathways are maybe dislodged or destroyed, and that can teach us how the normal immune system works. So we set up local biobanks and patient registries, and we used the clinical findings and the patient samples in this research effort. And several models were developed, and one of the seminal findings of this consortium was identification of a new parathyroid autoantigen, which is associated with hyperparathyroidism, and we can measure this in the patient samples, and Olle will go more into that. But about 50% of the APS-1 patients have these NALP autoantigens. But then the question is, how many APS-1 patients are there? And I think for sure we're not diagnosing everybody, and some are never diagnosed, some are diagnosed very late. I'll give some examples illustrating the wide clinical spectrum we see. This is a very nice, comes from a very nice paper of Jaakko Perentupa, the grand old man of APS-1, professor in pediatric endocrinology in Helsinki. He's now well over 90, I think, and still active, a little bit at least. But he followed the Finnish APS-1 patients for 4 decades and could show that some of the components come very early, like Candida we've heard, the recurrent fever, the keratitis, the malabsorption, hepatitis, while other manifestations come very late in the disease. So there are different manifestations for different ages. So one of our patients, he is now 67. He got Addison's when he was 20, which is not an uncommon age for a typical Addison patient. And he got his replacement therapy, lived a normal life, active in every way. But then in his 50s, he started to experience muscle stiffness and cramps. One sister had alopecia, another had vitiligo. So he contacted his doctor and they found a low PTH and a low serum calcium. I'm not sure what this is in US values, 3 or something? Or? 4. So he had a hyperparathyroidism and was treated with vitamin D. He had interferon omega antibodies, so we were pretty sure he had APS-1. And we found he was homozygous for a new ear mutation. Curiously enough, we had in our registry already 2 persons with this same mutation, sister and brother. They came from the same area, so they probably are related, most probably related. He had antibodies against different 21, he had tryptophan hydroxylase, 17-hydroxylase, and of course APS-1. When we then checked him up, we found that he had B12 deficiency. We also did a gastroscopy as part of our workup. He hadn't experienced any swallowing problem, but he had this candidiasis in his esophagus. He had autoimmune gastritis, but a normal duodenum. So this illustrates that you should really follow these patients up in a structured way, and it's important to treat and discover these other components. We kind of maybe expected some of the siblings to have APS-1, but they didn't. Another kind of unexpected case was this male patient diagnosed with Addison when he was 12. He had no other mutation, but we screened some of these young Addison at young age for APS-1, and he indeed had APS-1. He has now developed his second manifestation, which was candidiasis in his esophagus. He went to a Christmas party and a piece of meat got stuck in his, and then that led to the diagnosis of candidiasis. The latest development is that we found evidence of not only recessive inheritance in APS-1, but also apparent dominant APS-1. This started with this family here, the index patient got Addison's disease and candidiasis in his 20s. He was quite a productive, or should I say reproductive person, because he got siblings with three different women. And from his first marriage, his daughter developed hyperparathyroidism and also ovarian insufficiency in her teens. Then he had a second marriage with 2 boys, one that we wouldn't participate, and then with the third woman here, he got 4 children. The first had alopecia and nail dystrophy. This guy here has no clinical manifestations, but he had some APS-1 typical antibodies, and the third had hypoparathyroidism and premature ovarian failure. When we sequenced this family, we found only 1 mutation located in one special domain of the APS-1 protein, the PHD1 domain. And all the affected had the same mutation. We could also see that the different siblings with mutations had inherited different maternal alleles. So disease followed one allele from the father. We then try to look what is the mechanism for this dominant effect. So this is a bit complicated, but what we wanted to do was to see how this mutated protein works. So ear turns on certain genes, we call them ear-regulated genes, whilst others are not affected by ear. So we put ear into a special cell type and asked the question, will it turn on ear-dependent gene transcription. So this Finnish mutation, as expected, did not turn on ear transcription, but when we added a wild-type ear, we were able to rescue ear-dependent description. Then we tested the only known dominant mutation in ear previously known. It didn't support alone ear-dependent transcription, but also when you added the wild type, you couldn't rescue ear-dependent description, so it had looked like a dominant negative effect. And this family's mutation also behaved in that way, so it had a dominant negative effect. We then looked at several of the mutations in this PHD1 domain, and they behaved the same way with a dominant negative effect. And when we looked back in the literature, many of the patients with mutations in this particular domain have only found one mutation. They're only reported with one mutation. So it kind of indicated that there could be a dominant negative effect. So we then started to search for different families in our registry. We also got hold of a pernicious anemia cohort, a vitiligo cohort, and could show that in these families, monoallelic mutations in the PHD1 domain gives autoimmunity. Some fulfill the clinical criteria for APS-1, but most do not. They have a milder autoimmune disease. So all of these mutations are located here in the PHD1 domain. And when it's not so many families, but if you look at the typical classical APS-1, they have interferon antibodies, they have the main manifestations, hypopara, Addison's, they have Candida, they have vitiligo, they have B12 deficiency. But when you look at these with only one PHD1 domain mutation, they have less manifestations. Not all mutation carriers are sick, but there seems to be a propensity to develop vitiligo and B12 deficiency for some reason. So it's B12 deficiency is even more common than in the classical type. So if you look at the structure of the PHD1 domain, we think that key residues, when they are mutated, you destroy the domain, and this mutated protein affects the function of the wild type protein. So back to again to the European registry. I think I'll have to close, otherwise Olle will not have time to speak. But as we've heard, APS-1 can be a dangerous disease, and unfortunately, sometimes patients do not get to be diagnosed. Some die before diagnosis, and this is one example where on autopsy the whole adrenal cortex was destroyed. We know that mortality is increased in Addison's disease and especially in APS-1, but many of the causes are treatable. So I think if we can treat and follow the patients in a good way, we can avoid many of these mortalities. So the mortalities in APS-1 is related to cancer of the esophagus and the mouth. So don't smoke, don't drink excess alcohol, and treat the candida. It's very important also to avoid hypocalcemic crisis and adrenal crisis. And one of the efforts of this European Addison Consortium we have, and this was developed idea by Olle, is a steroid card that is common for the whole country. So he developed this Swedish cortisol emergency card with English on one side, Swedish on the other, and it's now been spread throughout Europe. And I think for Canada it will be perfect to have English on one side and French on the other. Don't you agree? So now the European Endocrine Society has approved this card. So I think if you have a card that every patient with Addison's carry, I think they can get the right treatment when they come to the ER. So this was a result of the this so-called urodrenals cohort. I don't have time to go into the registry details. We can discuss it afterwards. But one thing with these consortia and networks is that we can, it's not many clinical studies in this area, but bringing together all the experts in the area, we can define guidelines. I think that will improve patient care, and we've done some efforts in that area. So there are some outstanding questions that we can discuss afterwards, and also based on what Olle will tell you. What is the best practice with currently available treatment? I think we can define that now, both in regards to replacement and immunotherapy for some manifestations. But also we should discuss how can we cure this disease. And I know several of you have some ideas in that area. And I think a transatlantic APS-1 network would be very nice and build on the experience you have in the US and what we have in Europe. So with that, I think I'll close and give the word to Olle, who will continue.